Thank you so much, Kate. And I just want to thank you both so much for letting me talk about physical function and dementia, particularly when the attention is often on cognition. I'd also like to just acknowledge the co-authors of this chapter, Susan Muir, who's a physiotherapist, and Professor Manuel Montero Adasso, who's a geriatrician, both in Canada, and have both done a lot of work in this area as well. So I'm just going to start really by talking about mobility and why it's important. So mobility is really just our ability to move around. So whether that's getting out of bed or walking, really important for us to be able to do a number of activities of daily living, but also to get out and meet with others and socialise and do all the leisure activities that we enjoy doing, whether that might be golf or bowls. And unfortunately, after a diagnosis of dementia, some of these activities stop or decrease. And so mobility and maintaining mobility is really important. We also know that mobility impairments are associated with a number of adverse outcomes, such as falls, as Sue mentioned in the first talk, and also hospitalisation. So we can measure mobility in a number of ways. We might just describe it and say it's unsteady or it's slow. But I think it's really important that we do measure mobility objectively, because it gives us a really good idea of how anybody might function in the community. So we often do this with gait speed. So gait speeds of 0.4 metres per second are thought to be what's needed to be efficient in terms of walking about at home. Speeds of less than around 0.8 to 1 metres per second or less have been associated with both falls and hospitalisation. And really interestingly, you need a speed of around 1.2 metres per second to cross the road before the traffic starts coming the other direction. You do get to walk a little more slowly around nursing homes and some hospitals where they set the traffic lights at around 1 metre per second. So you can see it's important to know how fast someone can walk so that they can access the community. In research, we often measure gait looking at something like a gait mat, which will automatically measure gait speed. But in the clinic, and this is what we do in the cognitive clinic down at Peninsula Health in Victoria, we just measure a distance in the hallway and we use a stopwatch to measure the time that someone takes. And to measure gait speed, you just do distance divided by time. If you don't want to do that, you can even use an app on your phone that will calculate it and time it and calculate it automatically. So I was really interested in what happens when you get dementia to your gait speed. So this was a study that was in a cognitive clinic sample. And so you can see here that we measured people at their preferred walking speed, their fast walking speed, and also something called walking speed reserve, which is just the difference between preferred and fast speed, because we wanted to know what capacity people had to increase their speed as a measure, excuse me, of how much extra they had. So you can see that the bar that's black is people who didn't get a diagnosis of dementia or cognitive impairment. The next bar is mild cognitive impairment, followed by mild dementia and moderate dementia. And you can see for both preferred speed, fast speed and walking speed reserve that with each cognitive stage, the average gait speed was slower. But what I think is really important is that all older people attending the clinic did not reach that speed of 1.2 metres per second required to cross the road. And most people with a diagnosis of mild cognitive impairment or dementia had gait speeds less than that 1 metre per second that put them at risk of falls and other adverse outcomes. So you can see how important it is to measure gait speed. So why might gait speed or mobility be poorer in people with dementia? Well, we know that things like balance, reaction time, muscle strength and vision, as Sue mentioned, all contribute to mobility. We know that this gets poorer with older age and chronic disease, but also with disuse and less physical activity, which does tend to occur with a diagnosis of dementia. But also we know that all of these are poorer in people with dementia than people without dementia. So is it just physical things that happen, or can also problems or changes in the brain be involved? Well, We used to think that walking was just an automatic activity, but we now know that many different cognitive functions, are associated with poorer mobility. And I just want to give you some examples here. So if you imagine that you were going to navigate through this picture on the left, you'd need to have good planning to decide which route you were going to take. You'd need good judgment about your own ability to get through there. And you'd need good visuospatial skills to make sure that you didn't step in any of the cracks in the pavement. This middle pictures must be familiar to most people. You need to be able to divide your attention these days to walk about, talk to others and look at your phone. And as a physiotherapist, we do see a lot of people who can't or haven't been able to divide their attention appropriately and may have sprained their ankle. But this picture on the right shows what happens when we get older and our balance gets poorer, that walking becomes an attention demanding activity by itself. And you can see that it would be difficult, and this person would need good reaction time and processing speed to stop a fall if they were bumped. So we do know that many of these cognitive functions are important and are associated with poorer gait, even just in flat normal walking. But the good news is that exercise, and I'm going to use that word again that's already been mentioned a number of times tonight, can improve physical function in people with dementia. And I do remember many years ago a young physiotherapist asking me whether people with dementia can improve. And we now have really good evidence that we can improve people's functional strength, balance, mobility and endurance. And if the clinicians or anyone's interested, this article down the bottom here by Lamb in the Journal of Physiotherapy in 2018, which is an Australian journal, really does summarise nicely the evidence. As Sue mentioned, the evidence for falls is less certain, particularly for exercise. It likely requires multifactorial interventions, and there's been very few studies to date in people with dementia, although there was a recent one actually by a group by Morag Taylor in New South Wales that showed that exercise and some home hazard modification can reduce falls in those that had better physical function to start with. So that's good news. So what about the types and the principles of exercise? Well, most people have heard of exercise and they normally think of aerobic exercise, which is when you huff and you puff, and cycling and walking are kind of good examples of aerobic exercise. There's resistance exercise, which is when you lift weights and strengthen your muscles. There are balance exercises, so this is an example standing on one leg, and then there's functional exercises, which are the activities that we do every day, like sit to stand and climbing stairs. So the evidence for improving physical function is that we need to do multimodal exercise of sufficient intensity. However, I think it's important to realise that if you have a particular impairment in one of these areas, then improving that area is probably going to give you more bang for your buck. And also we know from the general older population that particularly functional and balance exercises are important to prevent falls. In that study that I mentioned, they found that more than 3 months, 2 or more times per week for 60 minutes was required, but I'd like to argue that the earlier you start, the better. It's never too late to start, and a lifetime of exercise is important. If people don't know where to start, sometimes the easiest thing to do can be to reduce the sitting time. So I'm standing giving this presentation because I sit a lot of the day at a desk. You don't have to do 30 minutes or even 60 minutes all at once. You can break that up into 10 minutes 3 times a day if you want to. Make a habit of it, and maybe even try and incorporate it into everyday activities. So you might want to do a balance exercise or rise onto your toes while you're waiting for the kettle to boil. To keep motivation, going with others can be really helpful. And during COVID, we actually put together a whole range of different exercises at different levels for people, older people, to do at home, and you can find that at that website there. But if you're uncertain or you're starting exercise for the first time, or you feel that you have a particular impairment in one particular area, seeing a physiotherapist or an exercise physiologist is beneficial. If you're a clinician, it's important to know the cognitive impairment that somebody may have, because that can really mean that you can tailor the way that you deliver the exercise so that the person is going to benefit the most. And I've just popped a couple of strategies down there for each different type of cognitive impairment, but the book does have more examples there if you're interested. But for example, if someone has poor memory, then you may need to repeat the exercise more time and give frequent feedback rather than waiting to give feedback later on. So I'd just like to finish really with saying that we know that all health professionals from studies have been found to have quite poor knowledge and confidence in treating people with dementia, and this is a problem as we know that there's going to be more and more people with dementia, and we see people with dementia for various other problems, and so we really need to know how to best treat people with dementia. There are also attitudes and beliefs that I think need to change, and this is something that I'm very passionate about and have a PhD student working on at the moment. We need to make sure that sport and leisure clubs are dementia friendly, and we also need to have people living with dementia, their families and the general public knowing about the evidence and what can be done so that people can advocate for themselves. Cognitive clinics are where diagnoses are often made. They're often multidisciplinary, which is fantastic, but they often don't include an exercise professional or a physio who might be good at looking at someone's mobility and falls risk. So I think that's really important as well. So I really hope that we can change people's knowledge, confidence, attitudes and beliefs so that we can make sure that people with dementia maintain function and participation for as long as possible. Thank you so much.